Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is September 22nd, 2025. This video is on two articles in the Lancet, two original articles, and one commentary. The first article is from the Victor trial titled Vericiguat in patients with chronic heart failure and HFrEF, a double-blind, placebo-controlled randomized phase 3 trial. And the second original article, is Vericiguat for patients with heart failure and HFrEF across the risk spectrum, an individual participant data analysis of the Victoria and Victor trials. And there's an accompanying commentary or editorial titled Vericiguat across the heart failure spectrum. The Victor trial. Vericiguat is an oral soluble guanylate cyclase stimulator that restores nitric oxide cyclic GMP signaling. Approved for worsening heart failure with HFrEF based on the Victoria trial. The objective of this Victor trial is to assess the efficacy of Vericiguat in HFrEF patients without recent worsening, no hospitalization in past 6 months, or outpatient IV diuretics in 3 months. The study cohort comprised of 6,105 patients randomized, 3,053 to Vericiguat and 3,052 to placebo across 482 sites in 36 countries. Follow-up median 18.5 months. Demographics: median age 68 years. 76.4% were male, 64.4% were white, 79% NYHA class 2, mean left ventricular ejection fraction around 30%. The treatment was involved Vericiguat titrated to 10 milligrams. About 85% achieved the target dose. Statistics: intention to treat, Cox model for hazard ratios, and a significance threshold p-value less than 0.025 for primary endpoint. What did they find? Primary outcome: no significant reduction in cardiovascular death or heart failure hospitalization. P equals 0.22. Cardiovascular death reduced, hazard ratio 0.83. All-cause death reduced, hazard ratio 0.84. Heart failure hospitalizations were not significantly reduced, hazard ratio 0.95. The limitations: primary endpoint not met, secondary endpoints nominal. Study excluded high-risk patients, NT-proBNP above 6,000 picograms per ml. Key takeaways: Vericiguat may reduce mortality in stable HFrEF, but not heart failure hospitalizations. Further trials are warranted to explore mortality effect. Background and methods of the second study, Vericiguat across the HFrEF risk. The objective was to evaluate efficacy across a spectrum of worsening heart failure risk using NT-proBNP quartiles. 4,856 patients in Victoria trials with data on NT-proBNP were enrolled. Subgroups: quartile 1 was equal to or less than 2,000 picograms per ml NT-proBNP. Quartile 2, 2001 to 4,000 picograms per ml. Quartile 3, 4,001 to 8,000 picograms per ml. And quartile 4, greater than 8,000. Follow-up median about 10.8 months. Demographics: median age 67 years. 76.4% were male. Mean LVEF was around 29%. 40% were diabetics. Statistics: adjusted Cox regression for hazard ratios. Analysis was stratified by NT-proBNP quartiles. The outcomes were cardiovascular death or heart failure hospitalizations. What did they find? Primary endpoint: relative risk reduction for cardiovascular death or heart failure hospitalization improved in quartile 1 to 3, hazard ratio 0.78, p-value less than 0.05. It was attenuated in quartile 4. hazard ratio 1.15, p-value greater than 0.05. Mortality, absolute risk reduction was higher in quartile 2, 5.4%, and quartile 3, 4.5%. Limitations of the study, it was a post-hoc analysis, not powered for quartile comparisons. NT-proBNP may fluctuate over time. Key takeaways, Vericiguat shows consistent benefit in low to mid-risk HFrEF, NT-proBNP equal to or less than 8,000 picograms per ml. Caution, diminished benefit at very high NT-proBNP levels greater than 8,000 picograms per ml. Risk stratification critical for clinical decisions. The accompanying editorial discussed these two key findings of the Victoria and the Victor trial. The Victoria trial showed decreased primary composite endpoints of cardiovascular death or heart failure hospitalization, driven by fewer heart failure hospitalizations, while the Victor trial showed no significant decrease in primary endpoint, but decreased cardiovascular death and all-cause death. Pooled analysis of 11,155 individuals, significant decrease in cardiovascular death or heart failure hospitalizations, p-value 0.0088. Cardiovascular death, hazard ratio 0.89, all-cause death, hazard ratio 0.90. Borderline heart failure hospitalization impact. Limitations. These trials differed in baseline risk, background therapy, and follow-up. Only 24% females, real-world generalizability limited. Key takeaways, Vericiguat offers modest but meaningful survival benefits in well-treated HFrEF, suitable for high-risk patients intolerant to the full-dose quadruple therapy. Future phenotype-driven use, patient-centered outcome prioritization, and Bayesian pooled analysis should guide clinical decisions. This slide is a visual comparison of Vericiguat in Victor versus Victoria trials. I'll let you all read it at your own pace. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom.